Hello, everyone. Thank you so much for joining. Let's just give it a couple more seconds for people to join. I am really excited for today's conversation with Carlos Saldaña. Let's just give it a couple more seconds. And this is intended to be an interactive conversation. So as you are participating of this webinar, please make sure that you use the Q&A box to ask questions or to put them in the chat. Now, let's get started. So my name is Damian Cabrera. I am the program manager for the treatment division at NMAC, and I am super excited to be joined by Carlos Saldaña Ochoa. Carlos Saldaña is assistant professor of medicine at the Division of Infectious Diseases at Emory University, and Carlos will be providing a presentation on CROI highlights from this past conference in February. Carlos has dedicated years of research in advancing knowledge in the field of infectious diseases and public health, with a specific focus on Hispanic and Latino communities. And Dr. Saldaña work explores implementation science and involve innovative approaches to HIV cluster detection and response. So as we engage in this conversation with Carlos, please have in mind that this is an open space for everyone to make questions. We are in a community space, and the information that Carlos will be providing will be is intended to be accessible to our community so that you can take this information and bring it back to your community, specifically as we have so many technologies in the pipeline, so many things that are closer than that we might think in terms of treatment and prevention. So we are going to have an exciting conversation with Carlos. And before that, I also wanted to mention that if you want to learn more, not only about the science and implementation science that we'll be talking today a little bit about, but also about HIV in general, in terms of stigma, in terms of prevention and treatment, please make sure you visit CDC Let's Stop HIV Together campaign. I will be putting some links on the chat where you can find more information. You can find social media toolkits with captions that you can use on your own social media. And also you can even order HIV test at home. And also now about today's agenda. So Carlos is going to present, and Moises and I will be navigating a community conversation with you all to ask more questions to Carlos and really be in community and learn more from each other. So now I will pass it to Carlos. Again, Carlos, thank you so much for your time, for your dedication, and you can take it away.
Thank you so much, Damian. Are you able to see my slides?
Yes, I can.
Perfect. So, thank you so much, everybody, for attending this update. I have nothing to disclose related to the content of this talk. However, as you know, CROI features a large number of abstracts across prevention, treatment, and cure, and I'll focus on selected highlights that are most relevant for us as community, for us as people that engages people living with a risk of acquiring HIV. So I want to apologize in advance if I don't cover work that you found particularly important. So these are the objectives of our talk. I'll start by reviewing emerging treatment and prevention strategies, mainly looking at long-acting approaches. This includes capsid inhibitors like lenacapavir, broadly neutralizing antibodies, next generation's integrase inhibitors, and the key theme is that we're moving towards less frequent dosing and more flexible regimens. We're also going to be talking about STI prevention with doxypep. We're going to be talking about real-world data of how this prevention tool is helping reduce new sexually transmitted infections. We're going to be talking about comorbidities and people living with HIV. We need to start talking about cardiovascular health, brain health, and how some markers and medications can help keep our communities healthy. And finally, we're going to be looking at updates in HIV cure and vaccine research. I want to highlight again, as Damian mentioned, that I've done my best to try to digest the language and the science into a language that we all can have a conversation. If something is not clear, please feel free to put it in the chat. We can discuss it and try to bring it to a understandable level. So please feel free to interrupt me or put it in the chat if something is not clear. So what is CROI? So CROI was founded in 1993, and it was founded at the height of the early HIV epidemic. The goal was to bring together scientists, clinicians, and community voices, which is still at the core of the meeting. And over the years, we've seen major advances in how HIV is being managed. We've seen effective antiretroviral therapy. During these meetings, we also presented U equals U, HIV prevention strategies, and most recently, doxypep and long-acting therapies for HIV and treatment and prevention. And this is not just an academic meeting. This is also a meeting that produces practice-changing data. And today is one of the most influential HIV conferences. So with that, what we're going to be talking is a little bit of the highlights of this meeting. And I want to start by some of the plenaries of this meeting. And one of the most powerful ones was delivered by Peter Stanley. He is a longtime activist. He talked about how 2025 was described as annus horribilis for HIV and public health. We saw major threats to fund it with research infrastructures and global programs like PEPFAR. He reminded us that science and activism are always linked. He told us the story about how activists pushed science to reshape clinical trials, to reshape access to medications and treatment. And this is, thanks to this collaboration, is that we have the progress that we have today and that we will discuss in the subsequent slides. He warns that the gains that we've had in 40+ years can be rolled back quickly if we remain neutral or quiet. And his call to action was very direct. There are ways to resist publicly, but doing nothing is not an option. Another important plenary comes from Wesley Sanskitz. He spent decades studying the viral shell or HIV capsid that protects and transports the virus from cell to cell, and now has directly informed the development of lenacapavir, one of the hallmarks of this conference, and really groundbreaking in the treatment of HIV, and how it informs HIV prevention and treatment that can be dosed as infrequently as 6 months. So this is a clear example of how a career of decades of dedicated basic science has led to the development of a completely different drug class. And it highlights the importance of sustained NIH-funded research. A reminder that these breakthroughs don't happen quickly, that don't happen just in a few years, but they build over time, but cause paradigms shifting care. So let's talk about what is new in HIV treatment. So this slide highlights the HIV life cycle, basically how the virus enters the cell, copies itself, and then moves through the body and unfortunately infecting other cells. So what is important to know is that the current medications target specific steps in the HIV life cycle. And what is exciting from CROI is that we now have newer drugs targeting even more steps, especially the capsid, which is a new target for drugs that, as we mentioned, last much longer, and we're seeing medications that prevent entry of HIV into the body. We are seeing medications that stop the virus from copying itself. We are seeing medications that block the HIV virus into combining itself into the human host cell DNA. And then lastly, capsid inhibitors, which block how HIV virus is built and then exits the cells and go on to infect other cells. I want to review the mechanism of action of lenacapavir because we're going to be talking profusely during the next slide. So lenacapavir, again, is a capsid inhibitor, a viral shell inhibitor, meaning that it targets that outer shell of the virus, which plays a role in several steps of the HIV life cycle. Unlike other drugs that target a single step, lenacapavir works at multiple processes, for example, limiting access of the virus into the nucleus of the cell, limiting the virus being built and released, and also impacting the formation of the capsid of the virus. So this multi-step action explains why it is effective in people with sometimes multi-drug resistance HIV and why it's being developed as a long-acting therapy. So one of the interesting studies presented at CROI is this study that looked at 171 people newly starting HIV treatment who became undetectable on pills. And these 171 people were given the option of remain on therapy or switch to injectable medications. Of those 171, 129, so the vast majority, chose injections, which tells us that there's a real demand for alternatives to daily pills. Importantly, the people that switched to injectable medications, around 9 out of 10 stayed undetectable with very low treatment failure and minimal development of resistance. I think the big takeaway is that not only that injectable works, but people want options, and having choices in how to take a treatment can improve engagement and long-term success. Another study, this is a phase 3 study, the Artistry 1, this is abstract 181 at CROI, look at people with long-standing HIV who were taking complex regimens, many times multiple medications a day, and multiple doses a day. And in this study evaluated into switching them to a single pill regimen that contained the medication bictegravir and lenacapavir. The key finding is that remaining undetectable was high in 96% of the people, comparable or even slightly better than people that were taking this multiple pills complex regimen multiple times a day with no emergence of resistance. Importantly, in these participants, we also saw improvements in cholesterol, suggesting that there's a potential broader health benefit. And most participants, these are people that have been living with HIV for 28 years, taking many pills. And this study shows that we can switch them with to a single tablet daily regimen. So in this study, the main takeaway is that for people with long treatment histories and even complicated regimens, we can simplify treatment without losing effectiveness and potentially improving health, as we saw here with cholesterol. This is another phase 3 study. This is the Artistry 2, abstract 513, that look at people who were already undetectable in a single tablet regimen and evaluated it, switching them to a new combination of a two medication single tablet regimen of bictegravir and lenacapavir. The key finding here is that suppression, being undetectable, was maintained at very high rates, at 93% compared to staying on bictegravir, tenofovir, alafenamide, and emtricitabine, showing that switching to this newer regimen is just as effective as staying on current therapy. There were few cases of viral rebound and one case of resistant occurred in a person who had seen integrase inhibitors in the past, which highlights that treatment history is still important when selecting these newer regimens. I want to talk about this new daily pill option that combines doravirine plus islatravir. This is a study that evaluated people switching from being undetectable to a once daily regimen combining islatravir plus lenacapavir. The key finding is that viral suppression was maintained in the vast majority of patients with no reported treatment failures in this early study. And this is important because it represents a major shift to daily pills and potentially to even weekly doses with phase 3 studies already underway. So another important study showing us that we can have simpler regimens. This study looked at a new 2-drug pill combining, again, doravirine and islatravir, and tested whether virally suppressed people who could switch to it safely. And the key finding is that it worked just as well as standard regimens, and at 96 weeks, it still had low rates of resistance. However, it's important to notice that there were some people who developed hepatitis V, and this is either a reactivation or a new infection after switching, because this regimen does not protect against hepatitis V compared to some other HIV regimens. So it's important to screen and vaccinate for hepatitis B when switching to regimens containing that do not have tenofovir. This is another study, a randomized trial evaluating doravirine plus islatravir as a first-line treatment option compared to standard of care. This is compared to a 3-drug regimens and comparing these 2-drug regimens. And the finding is that a 2-drug regimen performed just as well, with about 91% of participants achieving viral suppression at 48 weeks. Resistance was uncommon, with similar gains and with similar gain weight between the two groups that suggests that there's no major metabolic disadvantage. However, again, we're seeing occurrence of hepatitis V infections in this tenofovir sparing regimens, because again, these regimens do not treat hepatitis B. So it's important to screen and vaccinate for hepatitis B. This study looked at results from the Embrace trial. This is abstract 178, and evaluated a new approach combining new broadly neutralizing antibodies. This is a medication called lotivibart every 4 months with long-acting cabotegravir every 2 in people who were already undetectable. The key finding is that people remain undetectable in around 94% of participants, showing that this combination can be highly effective. And this is important because it introduces a new class of therapy, antibodies, into the long-acting HIV treatment strategies. Ongoing studies are looking into pushing this even further, with the goal of dosing every 6 months for this antibody. And also we're looking at studies looking at ultra long-acting cabotegravir, which can be given every 4 months. So the broader implication is that HIV treatment may soon evolve into very infrequent doses, which can significantly improve convenience and adherence. I think this is a worthwhile mention of a study looking to move away from daily pills. This is a twice-a-year shot that forms a small implant under the skin that slowly releases the medication over time. And the drug used here is doravirine, which is already an approved medication for HIV. And this is just a new way of delivering. This study looked at animal studies, and the implant released the medication steadily for up to 6 months, and the drug levels stayed high enough to be effective. It also, in this animal study, looked at safe, and it appeared to be very safe. And when removed, the levels of the drug went down quite rapidly, which could avoid having those long drug tails that can sometimes breed resistance in the virus. So it's good that once they remove this implant, we see the drug level go down as rapidly. So the big picture is that this could become a twice a year HIV treatment option, which can be a major shift for people who struggle taking daily medication. And it could be paired with other long-acting drugs like lenacapavir to create a complete treatment strategy without pills. So the next step is to fine-tune the dosing and start human trials. So this slide highlights several long-acting drugs that are in the pipeline. This include a new type of capsid inhibitor other than lenacapavir that it's in phase 2 and 3 trials, and also includes, and we're going to be talking more in detail about the pill, monthly HIV prevention pill that is coming from Merck, and expanding HIV prevention options. We're seeing cabotegravir that it's already approved with Retroviruses every 2 months, and we're looking into pushing this into ultra long active. We're looking at lenacapavir and other antibodies that can be given every 6 months, and we're looking at lenacapavir that it's being dosed and tested on a yearly basis for potentially for treatment. So what this what does this mean for HIV treatment? So for people that are doing well on treatment, having new daily or weekly regimens and fewer drugs allows for more flexibility and simpler options. Or maybe people that are struggling with daily pill, can we offer them long-active options that can be given every 6 months? This may improve adherence. And but some of the things that we're seeing in implementation is that we need to have the systems that allow for proper follow-up and medications and the staff to provide proper treatment of these modalities. And also for people that have drug-resistant HIV, having new drug classes can allow us to have more effective options and potentially simplify complex regimens. So these are the updates in HIV treatment. I now want to move to HIV comorbidities. So this is an analysis from the Reprieve trial, and it looked at inflammation and heart disease in people with HIV who were otherwise considered low to moderate risk of cardiovascular disease. So these are people that are undetectable. And what they found is that even in people who are undetectable, there are higher levels of inflammation and early signs of cardiac stress. So they measure markers like hypersensitivity, C-reactive protein, interleukin-6, and troponin, and these were associated with higher risk of heart events. The key takeaway is that it's not about just controlling the virus, but we also need to address long-term risks like heart disease. It reinforces strategies like lifestyle changes and medications like statins, and also weight loss to keep people living with HIV healthy. This is a segue into new guidance from the American College of Cardiology, recommending the broader use of hypersensitivity C-reactive protein as a marker for inflammation, and to assess the risk of people as a prevention for cardiovascular disease. So the key idea here is that we would be measuring this marker and start having tailored conversations with people about how can we decrease their cardiovascular risk, whether it's starting statins, lowering weight, increasing exercise, quit smoking. How can we have our communities remain healthy? This other study from Reprieve looked at whether statins could reduce the risk of developing high blood pressure in people living with HIV. And they found that taking a statin called pitvastatin had a 17% lower risk of developing high blood pressure compared to placebo. And this is important because hypertension significantly increased the risk of cardiovascular events. And in this study, it was associated with more than double the risk of major cardiovascular outcomes. So the broader implication is that statins, pitvastatin, atorvastatin, rosuvastatin, provide benefits beyond lowering cholesterol, likely reducing inflammation and improving our heart health in people living with HIV. I really like this framework on brain health in people living with HIV. This is abstract 20 that highlights that brain health in people with HIV, it does not exist in a single bubble. We need to talk about vascular health. How can we optimize and reduce the risk of strokes, of injury, of falls, of blood pressure, diabetes care in people living with HIV, but also prioritize sleep. Poor sleep, low quality of sleep also impacts brain health in our communities. So should we start screening and having people conduct sleep studies using their CPAP, or how can we improve sleep education? And finally, in terms of mood and social isolation, this also impacts brain health. So having people that experience loss of community and other environmental barriers like stigma, how can that influence depression and cognitive decline and increase our risk of developing dementia? But what we can do is provide and leverage community programs, social support, and group care. So again, this is brain health is multifactorial. It's not just a bubble. We need to start assessing cardiovascular health, ensuring that people are getting good sleep, and that we address mood and social environments for people living with HIV so we can improve their quality of life. This is a very interesting abstract looking at GLP-1 semaglutide and how it can be associated with reduced smoking. So this study looked at people living with HIV who smoked and started semaglutide, a GLP-1 medication commonly used, as you may be aware, in weight loss and diabetes. And they found that participants reduced their cigarette use by about 3 cigarettes per day, which is roughly a 26% reduction. And this is important because smoking remains one of the biggest drivers of poor health in people living with HIV, and as we're discussing, cardiovascular health. Well, this was not a study originally designed for smoking cessation. It suggests that semaglutide, the GLP-1, may have additional benefits beyond weight and glucose control, and there are ongoing trials looking directly into this association. So very, very, very interesting findings for GLP-1s and another use of semaglutide. I want to bring attention to oropharyngeal cancer in people living with HIV. Abstract 121 examined trends in oropharyngeal cancer among people living with HIV. They found that the rates of this cancer have more than tripled in the past 25 years, reaching about 29 cases per 100,000 people. The risk was higher in older individuals, people with lower CD4 counts historically, and people that are exposed to smoking and alcohol. So the key takeaway is that oropharyngeal cancer is no longer rare in people living with HIV. It reflects the trends that people living with HIV are living longer, and that the HPV-related cancer are highly prevalent in people living with HIV. So we need to focus our efforts on smoking and alcohol cessations, and also increase the awareness that this type of cancer is happening more frequently in our communities, and also disseminate education for early symptom control. Okay, so I want to talk now, we're going to be moving into HIV cure research. So where are we now? And Have we cured HIV? Not yet, but I think that compared to other CROIs, there has been very interesting trends on how to control HIV without daily meds, how to new ways to target the virus in the body, the role of antibodies, immune therapies, and even combination of these approaches, showing us that the progress is real, but still we have to be cautious in this field. There's this study, abstract 331, that looked at how the heating HIV reservoir, which is measured by intact proviral DNA. And this is the reservoir in which when people stop taking their medications, the virus rebounds. And the reservoir can change over time. We know that, again, this is the reason why the virus comes back after treatment is stopped. And we, in this study, we see that the virus in most people decreases early on, then stabilizes, and then even increases. The reservoir increases over time. However, in this study, we found that there's a subset of individuals that continue to have a decreasing reservoir in their body. And why is this important? Because it shows that in some people, they may have natural mechanisms that help the virus reservoir decrease over time. So more research should be focused on understanding these mechanisms so we can develop cure strategies. So really, really interesting data. So this is also data from the Rio study that look at what happens when people stop HIV treatment. They receive broadly neutralizing antibodies and then stop treatment again. So the Rio study found that after receiving antibodies, the virus took longer to rebound compared to the first interruption. So this suggests that antibodies may help the immune system control HIV temporarily without taking daily therapy. However, it's important that to mention that important questions remain, and whether this effect is truly due to antibodies or maybe partially due to repeated treatment interruptions. So the key takeaway is that antibodies may delay viral rebound, but there are no cure yet. And it seems that this effect is only temporary. Let's talk about HIV prevention. So I think that the Prevenir study, it was quite interesting. This is coming out of Paris, and it's one of the largest real-world PrEP study, following over 3,000 people in Paris for several years. Participants could choose whether taking a daily HIV prevention medication or on-demand PrEP, which is 2 pills 2 to 24 hours before sex, then 1 pill 24 hours after the 2 pills, and then 1 pill 24 hours after that pill. So participants were allowed to choose between daily, between on-demand PrEP, the regimen I just described, or switch between them. And the key finding of this study is that HIV infections were extremely rare in both. There was no significant difference between daily or on-demand PrEP, even though condomless sex increased over time. PrEP in both mechanisms, either daily or on-demand, work very well. So another important takeaway is the flexibility, that people who were able to switch between daily to on-demand PrEP were less likely to stop PrEP altogether. Side effects were uncommon. Hepatitis C, unfortunately, still occurred. So it's still it's important to have conversations about condoms to prevent other sexually transmitted infections. But overall, this study reinforces that on-demand PrEP is safe, effective, and an alternative to daily PrEP for men who have sex with men, and that giving people options help them stay in HIV prevention. We also saw updates on the Purpose 1 and Purpose 2 trials, looking at lenacapavir given every 6 months for HIV prevention. And Purpose 1 for cisgender women showed that lenacapavir reduced the risk of HIV by around 96% compared to daily oral PrEP. And in Purpose 2 for men who have sex with men, transgender, and non-binary individuals, the reduction was around 88%. This is, again, significant because it introduces a highly effective preventive option that requires dosing only twice per year. And this could overcome many of the challenges associated with daily pill adherence. But we continue to hear all over again that the prices and the implementation of this prevention strategies remain prohibitive, especially in areas in sub-Saharan Africa where the need is the highest. Very interesting. We continue to see the Purpose 365, which is pushing even the dose of lenacapavir, which is currently approved for every 6 months. And in this study, the investigators asked the question, can we push that even further to just once a year? And instead of starting from scratch, researchers used advanced modeling based on prior clinical trial data to predict what dose would be effective and last a full year. So the results suggest that a higher dose of 3,000 milligrams given once a year can keep drug levels high enough to stay protective this entire time. And it would also need a short lead-in of 2 days of a medication, oral medication, so the protection can kick off quickly. And based on this study, the Purpose 365 is underway and it's enrolling 300 people. So we are excited to see that we can have an HIV prevention strategy that can be given once a year. As a flu vaccine, I think it's quite interesting. Another potential option, the MK8527, it's a phase 3 study. It was presented as a once a month instead of daily medication or injection. This study looked at 11 milligrams and maintains protective drug levels in almost everyone at 95%. Importantly, it looks consistent across different populations, including pregnant individuals and people with mild kidney impairment. One practical advantage is that drug levels remain long enough, and it can even have a cushion of 1 week if we're late to take the medication 1 week late. So from an implementation lens, this could lower adherence burden compared to daily PrEP while avoiding injection. So now the key question is, will this translate into real-world effectiveness? And we're waiting to see phase 3 trials for this medication. One of my favorite studies coming from CROI this year, this is a real-world implementation prioritizing younger Latino men who have sex with men in California, in which pharmacists delivered PrEP and were able to provide same-day starts of PrEP with enrollments taking less than an hour. They advertised this pharmacy-prescribed PrEP program in social media with materials in Spanish that were tailored for Black Latino men who have sex with men. They were able to reach a group of 90% Hispanic, mostly around the age of 28, highly uninsured, or people experiencing poverty, and what some people call hard to reach, populations. They were able to get 102 prep start coming from 247 contacts. 100% of them initiated the medication within the same day. 78% of them were retained at 3 months. They even had 2 new HIV diagnoses that were immediately linked to ART. So the big picture here message is that pharmacy-based PrEP is scalable. It can be equity focused, but we're still are seeing barriers in terms of payer and workflows. But very exciting to see this work coming out of California. Another interesting and innovative model. This study looked to solve 2 problems at the same time: preventing HIV and preventing unintended pregnancy, which often happen in the same population, especially in women globally. So they used an injection that turns into an implant that lasts around 1 year, using dolutegravir to prevent HIV and levonorgestrel to prevent pregnancy. And they studied it in an animal model, and they see the drug levels lasted properly for around a year. It was deemed generally safe, with mostly skin reactions in the animal model, but the drug was properly released slowly and still steadily over time. And this could be a once-a-year option that provides HIV prevention and contraception. So again, the next steps would be tweaking the dosing and then testing it on people. So I wanted to highlight this study looking at innovations in implants and sort of addressing 2 issues with a single intervention. Let's talk about STI prevention now with doxypep. So for those of us who have probably not heard about doxypep, this is a strategy in which people take 200 milligrams of doxycycline, an antibiotic, within 72 hours. The sooner the better. And it has been mostly studied in men who have sex with men and transgender women, and has decreased the incidence of chlamydia and syphilis by around 2/3, lower effectiveness in gonorrhea. We have seen signals in Africa that showed maybe that it wasn't beneficial in cisgender women, but that has been attributed maybe to lower use. But there are pharmaceutical studies looking that there is there should be benefit in terms of drug levels, and there are ongoing trials to clarify this question. So that's doxypep. And what we saw at CROI 2026 is more of a real world data from studies coming from San Francisco and Seattle. And the clearest benefit was seen for chlamydia, in which people using doxypep had about 2/3 lower the risk of infection. We saw also reductions in around 80% decreases in some groups. However, the results were more mixed in other STIs. For example, for gonorrhea, doxypep did not consistently prevent infections. And unfortunately, this is important, in some cases, people taking doxypep were actually diagnosed more with this infection, which may reflect maybe antibiotic resistance, maybe that we are testing more frequently in this group, or changes in behaviors. For syphilis, infections still occur among people taking doxypep, and in some studies, there was not a clear reduction. For non-gonococcal urethritis, in the case of Mycoplasma genitalium, there was no impact in using doxypep. So I think the key takeaway is that for doxypep, it works for chlamydia, but not so much for other STIs like syphilis and gonorrhea, and that adherence is very important to see some of these benefits. In this slide, we see more data into real-world use of doxypep, and that first, the uptake is moderate or highly concentrated, mostly around MSMs and transgender individuals, primarily if they've had an STI in the past, or they have high partners or engage in chemsex. We see lower uptake in cisgender women and transgender and non-binary populations. So we see that there is still an equity gap in certain groups, and that another key message is that in groups that doxypep has been rolled out, we are seeing, of course, increased exposure to doxycycline and even more pressure and seeing tetracycline resistance in Neisseria gonorrhea. So here, the take-home point is that doxypep works, but scale must be tailored to groups that will benefit the most, meaning those that had a prior STI, that have high partner volumes or engage in chemical sex, and that we should continue to have a close eye and stewardship and antimicrobial resistance in groups taking doxypep. Another sort of disappointing finding is in the field of vaccine for gonorrhea. We had signals that meningococcal B vaccines had been associated with lower gonorrhea rates. So in this large randomized trial, there was no protection of a meningococcal B vaccine against gonorrhea. The infection rates were identical in vaccine when compared to placebo. There were no benefits in symptoms, asymptomatic infection on any side. However, this vaccine was safe, but ineffective in preventing gonorrhea. Study from South Africa asking women if they are willing to get such vaccine that would prevent gonorrhea. There's a very high willingness to receive a gonorrhea vaccine. And so the key take-home point message here is that the current MenV vaccine does not prevent gonorrhea, but there's a strong acceptability in groups, and that should support an investment in a gonorrhea vaccine. Now, let's switch conversations briefly to HIV vaccines. And again, same as in cure, we're seeing real progress or more enthusiasm for HIV vaccines. New approaches are getting immune systems to respond in ways that we couldn't achieve before. And that's encouraging and moves the field forward. However, we are not there yet. The vaccines still haven't shown reliable protection. So right now we have to rely on the tools like long-acting and daily and on-demand HIV preventions to prevent, and condoms to prevent HIV. So what are we seeing in terms of HIV vaccines? So this slide highlights where the field stands right now. We saw interesting abstracts showing that we can generate immune responses like antibodies and T cells, but they are not enough or broad enough to prevent HIV infection. We saw an abstract showing that neutralizing antibodies were formed in about half of participants, which is promising, but still not effective in preventing infection. And we also saw that certain vaccines can boost immune responses in people living with HIV, but still are unable to control the virus of therapy. So again, these vaccines are not strong enough to prevent HIV. Vaccines cannot reliably stop infections or replace antiretrovirals. And most vaccines have been generally safe and well tolerated, but still, again, not effective. So we also saw some studies mostly in animal models that using newer tools to deliver antibodies to infection sites, and in some macaque models, we have seen a reduction in infections of around 67%. We've also seen better T cells vaccines that target newer parts of the virus that are harder for the virus to escape and have shown to delay infection in certain animal models. We're seeing better ways into delivering the vaccines using adjuvants with virus-like particles. And another very interesting study is that looking at the microbiome, at the gut bacteria, and how having a healthy gut response may be linked to better immune responses. So I think the takeaway message here is that vaccines are still in development, and we're moving toward more precise or even better strategies into delivering these vaccines. So in summary, I think that what some of the take-home messages that we have is that HIV treatment is becoming more flexible. We're moving away from daily pills towards options that can be taken weekly, monthly, or even just a few times per year, and even possibly once a year. One of the biggest advances is lenacapavir, which is changing the landscape for both treatment and prevention. It works extremely well for HIV prevention, and it's being tested as yearly. We're also seeing newer, simpler regimens like 2-drug combination with switching strategies that can still provide people and with full protection and helping them maintain suppression or being undetectable. But it's important to screen for hepatitis B before switching or stopping tenofovir-based regimens. In terms of doxypep, we're seeing that it works really well in preventing chlamydia, but it's less reliable for gonorrhea and syphilis. And the benefit, of course, depends a lot on if people are taking it consistently. Importantly, HIV care is more than viral suppression. We need to focus on cardiovascular and brain health, talking about smoking cessation, talking about people about cholesterol lower medications like statins, and also brain health, not treating it as a bubble, but also as a multi-pronged approach. Finally, cure and vaccine research continues to move forward with some approaches showing that antibodies, for example, can delay the time in which the virus can come back. We see certain vaccines that can trigger immune responses, but these are not ready to change every day practice. So I want to thank several of my colleagues who provided slides that have shaped this conversation. And with that, I welcome questions, concerns, and conversation. So thank you very much.
Thank you so much, Carlos, for such a comprehensive presentation. Before we open it up for questions, I would like to pass the floor to Moises, who I know was covering specific tracks of the conference, particularly on HIV and aging. Moises, if you have any comments, any highlights that you would like to share. You're muted, Moises.
Always. Thank you, Damian, and thank you, Dr. Saldaña. Such a great presentation and very easy to follow I hope we can have copies of the slides. I know people
We
are
will.
requesting them. So I just wanted to highlight or ask a couple of questions regarding some of the issues that you raised. One of them I found it quite interesting was the whole plenary session that was dedicated to the GLP-1 medications, Dr. Todd from Baltimore. And one of the things that, he highlighted how it could benefit in different aspects of systematic health, including cardiovascular, inflammatory, and also one of the things that a question I had is like knowing that they may be all these benefits and now they are so available and people are using it for losing weight and diabetes and also their effect in cardiovascular. What is the potential, as an HIV doctor, what would be the potential of GLP-1 for managing multimorbidities in people aging with HIV? It seems like it could be a tool as a physician to tackle some of those issues that are now we're seeing in those of us aging with HIV.
Thank you so much, Moises, for that important question. And I really love that plenary session as well on the impact of GLP-1 for losing weight, for controlling diabetes, on decreasing cardiovascular risk, even improving mood and the willingness of people to exercise. I think it's quite interesting, and it's really nice to see that more options are being developed for GLP-1s that would include pills, that several pharmaceutical companies are putting products out that hopefully can decrease the cost. Because at this very moment, as a physician in the South United States, for people on Ryan White, for people that are uninsured or underinsured, it is extremely hard to getting these medications that have shown to have so many benefits. So I think that as a group here, we can continue to advocate and maybe sharing resources and providing people with self-advocacy, because there are ways, but it is really hard for us as providers if we don't have the infrastructure to apply for patient assistance programs, for navigation, for pharmacists to make these medications more available. But we're seeing important aspects also. We talked about reduction in alcohol consumption, in smoking, and as you mentioned, many other aspects that could make our community live healthier lives. But access, unfortunately, for the people that need it the most, many people in Ryan White programs or in AIDS assistance drug programs, it's very hard for them to access this medication despite them benefiting from them.
Very important. And one more thing about, it's interesting because this morning we were in a call regarding an issue that is coming out about compounded formulations of GLP-1s and how many pharmacies now are like selling this as equals, and there is no control over compounding formulations. So that people need to be aware of that, educated on that, and make sure that there are discussions with the doctors if they want. Sometimes people want something and they get it in any way or form they can. So it's important we are aware of that. The other thing I just wanted to mention about, there was some presentations about structural inequities on women, mostly trans women. And more about access to housing, access to transportation, and other social determinants of health that are getting in the middle of this population getting quality care. Anything that you remember that you want to share about women and trans women?
Yeah, this is really important, and we have unfortunately, I would have liked to see even more of science being directed or findings and impact for transgender groups and cisgender women. I think that this is something that we continue to see and we can do more. But especially in my particularly research sphere, if we're getting federally funded dollars, unfortunately, sometimes we see that we cannot enroll transgender individuals into studies. So the role of advocacy and being loud about this work remains more important than ever. We have learned important lessons in the HIV prevention field with mistakes like that were made for drugs like Descovy, and we see that now pharmaceutical companies are prioritizing cisgender women and transgender groups, but there's still a lot of work to do, especially from federally funded dollars, that it's harder to enroll transgender groups, or it's harder to look specifically into this traits because we all right now can only have two genders based on federal policy. So it's important to keep active in this group. Otherwise, we're going to continue to have disenfranchisement.
Yeah, thank you. Thank you. It was great to see a lot of presentations about women and researchers emphasizing that women was not just an special population, that they were central part of the response and the populations that are most effective. And in the aging population, women aging with HIV, that there was a higher burden of comorbidities in women that in men. So it's important that we keep an eye and monitor how the epidemic is showing up and how access is limiting some important populations. That's it, Damian. Thank you, Dr. Saldana.
Thank you, Moises. So there's a question in the Q&A box, and also Stephen, you can join the conversation if it's accessible to you. You can unmute yourself and join the conversation. But Stephen, question is related to doxypep, and the question is: should we exclude doxypep as being somewhat effective against syphilis entirely?
So I think that the jury's still out. We're seeing mixed results for syphilis. It's clear that for gonorrhea, it's a different study. And from the data that we're seeing primarily from San Francisco and Seattle, that were the groups that really spearheaded this intervention. Here in the South, we have been much slower. So I do think that it's going to be important to continue to offer it, have tailored conversations to people who are going to benefit the most from it. And that's going to be people that have multiple sexual partners, that prefer condomless sex, that engage in sex with substances. And this is important. So we're seeing that there may be an elevated pressure or resistance for development of antimicrobial resistance in certain bugs. So it's important to have tailored conversations and offer it for people that are going to benefit the most from it. And again, I don't want to discourage us thinking that because we're seeing some signals that gonorrhea may be diagnosed more frequently in people taking doxypep. But these are people that maybe are also engaged more frequently in the healthcare sphere, that are getting tested more frequently. So I think that's really important to consider. And so more to come in terms of doxypep. But as of now, I think that it has shown to decrease gonorrhea. We're also seeing important data from other STIs that are on a national sphere that are coming down for the first time. The only one that we're seeing that is going up consistently is congenital syphilis, and I think that that's mostly because of lack of access for screening and prenatal care in certain vulnerable groups.
Great, thank you so much. I have another a comment, because I think that for our particular context, meaning this call, we have a group of members from our programs, right? From the Gaming of Color Fellowship, we have people from NAN, from the HIV 50 plus to Unhealthy, from GLOW, from NextGen, which is specifically for youth, and GLOW for women. So I think we are in a space of advocates. But sometimes, working in this field for quite some time, I've realized that there are not many spaces for advocates to join clinical trials, for example, and to be able to support and provide feedback for clinical trials, and kind of to support determining the priorities, or to making sure the protocols really reflect the needs of the community. I do know some, for example, the Community Scientific Subcommittee of the ACTG, which I'm part of. It's one venue, but aside from that, I wanted to know from your experience, Carlos, if you have any kind of recommendations for people that want to do advocacy in this realm. What can they do? Where can they go? Where can they find resources?
So I think that what I've seen certain a lot of success is sometimes discussing directly with pharmaceutical companies, and because they are behind several of these efforts, and many of them are intentional in engaging people of color in their advisory boards. I am part of Beef Healthcare's Men of Color Advisory Board, and I think that important conversations have been had in how to promote this medication. So I know that there's the ACTG, there's also Centers for AIDS Research have the community liaisons. So locally, if you are near a university that is affiliated to a Center for AIDS Research, I would encourage you contacting their Center for AIDS Research and asking about their community liaisons. These are groups that do have that are presented with study findings on a frequent basis. So that's one option in the academic side, but also each of the biggest pharmaceutical companies also have community liaisons that can discuss about drug dissemination, outreach, etc. So I think it's quite important. So I don't know where most of us, but I know that several, if not all of the CFAR have Center for AIDS Research at university levels also have community. So that would be another thing.
Can I add? I remember that in the ACTGs, the ACTUs were supposed to have a community advisory board. Each one of the units, they are required as part of their grant. So those are perfect for people to go and look at the research centers and find out who is the point person for the community advisory board, and just immerse yourself in it. The CFARs, like Dr. Saldaña said, are good. They also all have community advisory boards, and in the community setting, there is a group named ATAC, which is the AIDS Treatment Activist Coalition. I think Rick wrote it in the chat. That's a community group, and what this group, which we're members of, they meet with researchers from the pharmaceutical companies. So every year there is a meeting with the scientists from Gilead, with the scientists from Merck and ViiV to discuss drug development. I mean, what you hear or discuss there needs to stay there. They make you sign a form, so for their confidential and protection of their copyright, I think, trademarks. But there are ways, many ways, and I think that Mian or myself also can help you to get connected to some of this group if need be.
Yes,
Absolutely.
and thank you for reminding me about the advisory boards. And the ending the HIV epidemics should also be jurisdictions should also be required to have community advisory boards. And I would say here in Atlanta, that's at the different stages depending on each jurisdictions. But if you live in an ending the HIV epidemic jurisdiction, I think contacting the health department, they are always looking for people to join their the community advisory boards, and going to these conferences. Just having somebody from a pharmaceutical company asking me last week if there are people going to Rio for the AIDS conference this year, because and we need more community advocates and talking about their expertise. Just I think another very powerful session was on long-acting injectables, and I think that CROI did a great job in which the first people presented the science, and then they had community advocates really bring the things up to speed and what is happening in the communities, what's happening in Latin America, what is happening in Sub-Saharan Africa, and really bring in that reality check that you're presenting really nice numbers, but this is not working in the communities. So having those voices, and especially if you have stories that you can share, or there's always very important, there are forums, and they're always looking, for example, in the Infectious Diseases Society of America, it has a scientific blog called Science Speaks. They're also looking for entries. So if you have a story that you want to share, if you have an idea, there are always blogs. And again, the Science Speak from the Infectious Diseases Society of America blog is a good avenue. They're always looking for the blog entries.
Thank you. Thank you so much for those recommendations. And also, now that you mentioned conferences, for those that are attending the Biomedical Summit, if you are going to a session, please make sure that you raise your hand, ask questions, talk directly to the presenters. It's a great opportunity for you to network. This year particularly, we're going to have a lot of research-oriented content, so please make sure that you also take that opportunity. And also the CAPs. Sometimes the protocols that are in development are taken back to local CAPs for feedback. So that's another venue, as Moises and Carlos were mentioning. There's a question in the chat, Carlos, from Pastor Andre, that mentioned in the light of the way present administration is addressing or not addressing things, do you have any plans to address straight heterosexual men in research?
That is a great question, and usually, I think that a lot of in this very limited environments in which funding is quite limited, sometimes pharmaceutical companies and research institutions see themselves trying to prioritize the groups that are seeing high STI rates or high HIV acquisition, so they can measure effectiveness. If a group is not seeing a lot of these outcomes, sometimes it's hard to prioritize them in certain research interventions. And we're seeing, and for example, and one of the worries that we're seeing from some of these from some of the abstracts is that sometimes you can see an increase in antimicrobial resistance, particularly if these medications are prescribed to people that sometimes not benefit the most. But I think that this is a call to providers and for the community to have these conversations. If I identify myself as a cisgender man and I have multiple partners, I would definitely consider prescribing these options of PrEP. PrEP is recommended for people that are for all people that are sexually active, regardless of their sexual orientation. So anybody that is sexually active should be aware of PrEP, and people that have multiple sexual partners or have had prior STIs should be prescribed HIV prevention, and should also be, it would be completely appropriate to have conversations about doxy-PEP. Sometimes I guess the question goes back to enrolling cisgender men into these trials and not being able to see the effectiveness or the outcomes because of maybe lower exposure. So then I think it's a little bit of a different conversation. So I don't know if I answered you.
Thank you. There's another question in the chat from Philip Russell, and this is regarding covering insurance covering long acting. And Philip mentions, are there any indications on faster insurance uptakes on long acting injectables, and will they start covering these extra long acting injectables on monthly pills faster as they release? Because the experience is that you go to the doctor, ask for this approach, and then you get approved for daily pills instead of the ones that you're asking for.
And that is a great question, and thank you for reminding me of some of the real world implementation aspects of this long acting medication. And it's quite disheartening that sometimes it is easier to get somebody on lenacapavir for HIV prevention if they are uninsured because of the pharmaceutical companies' patient assistance programs than somebody that has insurance. So I think it's quite hard, and let us that sink in, that sometimes it's easier if you are uninsured getting lenacapavir because of drug assistance programs than if you have insurance. So a lot of, and from my colleagues from all over the states, most of the people that are accessing lenacapavir for HIV prevention, it's because they are uninsured. So lots of work to continue to do in terms of advocacy and being loud about why is it that it's easier to access those medications if you're uninsured because of pharmaceutical companies' assistance programs versus people that are insured.
Thank you. And there is a question on the Q&A box, and I would like to ask you, Carlos, this question and myself, but also people in the audience if you want to come off mute, because I think that this applies all. With new prevention and treatment tools emerging, what guidance would you offer to help health educators communicate these advances in ways that build trust rather than overwhelm people?
This is such a great question. And, you know, even myself putting together the slides, even up until yesterday, I was trying to pull new abstracts and deleting some things because there's so much and it can sometimes be overwhelming. I think for us in this group, we can take one message is that scientists and providers are working hard to provide us with options. An option gives the patients the autonomy to pick what fits best for you. If you're somebody that feels fine taking a daily medication and this is part of your routine, that is fine. If you're somebody that forgets, please know that there are options that could provide you with coverage with longer acting, either coming up as a monthly pill, as a weekly pill, as a Q4, Q2, Q6, even once a year. So just knowing that there are options, and options puts the cards on your side as a patient, knowing that even if I'm somebody that have been living with HIV for decades, knowing that I can get on a medication, I can also be one of those people that can take a once a day medication because researchers, pharmaceutical companies, and communities are being loud about the fact that we need options. Because otherwise, we could have just stayed on a AAA or Gemvoya, but that doesn't work for everybody. So just know that there are options on the pipeline so we can have tools that fit my lifestyle. And my lifestyle changes. Maybe right now I like the pills, but then in a couple of months, in a couple of years, or if I want to take a long 6-month travel all over the world, I can take and not think about my medications. There are options for me and the changing lifestyle.
I think,
Moises, yes,
yeah,
go
I
ahead.
think there is homework to do here for us, I think at NMAC, in the sense that it's important to bring this information to the community. I remember the early days when protease inhibitors came that were kind of complicated regimens. People needed to learn about when you take it with food, without food, every 8 hours. And there was all these complications that if you missed taking it with food, maybe the absorption wasn't going to be good enough. So I think we're getting into a time with all these new formulations and long acting in which probably we need to reactivate networks of health educators and provide capacity building to them so they can be equipped to translate this information to the community. This was done before. It hasn't continued as it should, but I think now these times call for us to reactivate health education, education about trials, also education about how do you relate with your doctor, how to build for relationship with your doctor, and how to, for those of us aging, how do you now manage more than viral suppression? You're going to have to you're dealing now with multiple comorbidities, and these get complicated. Appointments get complicated. So I think that the role of the community health worker, health educator, it's an opportunity to enhance their role in bringing treatment and clinical information in a way that people can use it and understand it, and that translate to adherence, that translate to healthy living.
Yeah, and I think it all comes down to really the meaningful involvement of community, as we say, because there might be amazing advances in science, but if community leaders are not involved, these are the ones that are trusted by the communities. These are the ones that are going to pass down that information to their peers in a language that people understand, in a language that is accessible. So if we do not involve, if scientists don't involve community members meaningfully, with a purpose since the beginning, there's going to be a lack. And that's the history that we have seen in the past, right? PrEP came, there were many questions about it. And then we have seen it now with so many questions about whether the injectables or doxypep and things like that that are new, and community has questions. And it's important that we are the ones that peers get to talk to the community, and that means involving community and informing, like making an asserted effort to involve community members.
I agree, Damian. And as I was putting together the slides, it is very hard to digest this, not especially from basic science or the cure or vaccine research. But I think that you lead your communities. I can try to digest as much as possible, but now how can we? You speak the language. You open the path. So how can we continue to even digest more and then come up with our own agendas as to where do we want to head? Now that we understand these advancements, where do we want to go? I think it's been quite important, and that's one of the key messages of what Peter Starwood told us in the opening message.
And I also wanted to ask you, it's a very specific question about doxypep, because I do know that there has been some resistance in the sense of how useful it is, which we know that it is for some things and not that much for others. And you were mentioning new data about gonorrhea and kind of hinting at possible resistance development, which is what everyone kind of is afraid of. Are there any systems in place, let's say any surveillance systems that can track those resistance that are happening kind of in real time, or as much as real time as possible?
Unfortunately, those do not exist at present. And that is something that there's certain groups that are advocating for, especially because new treatment options are becoming available for gonorrhea. We have two new drugs that are being approved by the FDA as we speak. So it's really important to have important surveillance tools which at present in the United States do not exist.
Thank you. And I bring up this conversation, this question, because we have also seen, I remember last year when it was presented, the study from San Francisco, when doxypep was implemented, how the STI rates really lowered. So there is still the promise is there, but then again, I think the major concern is resistance, and it's an actual possibility. So we have to definitely keep an eye out for that. There's a comment, Carlos, on the chat from Steven Vargas. Or Steven, if you want to come off mute and ask the question yourself, Steven Vargas. You can come off mute.
Oh, yeah. Sorry, I didn't see how to do that. It just popped up. Gracias, Damian. I was thinking specifically around some of the cure research that you were sharing, Carlos. But then I think it applies across the board. Part of the let's see here. Part of the issue sometimes I think I have is putting things into practice and making sure that they're equitably accessible. And that's the main thing right there. And part of it when it comes to this is I think we need to start wherever we are, people living with HIV, wherever we're involved. You're talking about the various CABs and ACTG advisory boards, wherever we're involved, I think we need to start bringing up these conversations around how to integrate the information we're hearing, like at CROI, and the advances in how it for the implications for folks who help out on the policy side of things for Reinhardt planning councils. How could some of these affect it? Even beyond that, even more importantly, ADAPTs. We heard some questions already about ADAPTs, the lag in having updating their formularies to cover some of the medications and so on. And so just the involvement of people living with HIV, wherever we are, I think we need more information around how to communicate this information when we're thinking about policy implications on planning councils, when we're thinking about protocol design feedbacks, if you're doing some work as a CAP for a Center for AIDS Research Projects. I've even thinking about provider trainings for how to discuss research without misinformation, essentially. But how to do that, I'm not exactly sure. I'm not sure if we need to have a session designed where we could break some things down and what are the impacts, for instance, for planning councils and what policies you might want to implement on ADAP programs if you're on the advisory board, or CFARs, or even if you're in provider settings. That's the thing I'm thinking we lack. We hear this information. How do we integrate it in a way that it becomes effective with these other kinds of things in which we're involved, giving our recommendations and advice? So I think that's the piece that's missing.
Yeah, I think that that is an excellent point, and there's been strides into getting this knowledge disseminated in digestible ways. And I think that this year CROI had in each abstract, most of them complied, having a community lay language summary of the abstract in somewhere in the poster. But there's still a lot of work to do, and I think that this is up to the. I think this is the researcher's job. If you're dedicating your time into this work, you have to make it available. You know, I think that, and some people are very effective in doing that. I hate it personally when we have community and this scientific meetings, and I do this all the time, and sometimes I don't understand the thing. So I've seen community members stand up and be vocal about it and say things that, hey, I'm not understanding what you're saying, and you invited me here. So I think that being vocal in that way is very, very important, because this is our health, this is our community, And if there are people that are dedicating decades and decades in studying this, they are the ones that should be able to digest it to us. So it's easier for us to comprehend. So being vocal about it and holding researchers accountable for that, I think it's really important.
Great. Thank you so much. And we are 2 minutes over time, so I really wanted to thank you, Carlos, for your time. This presentation was really, really good. You were really able to digest all those complex terminology to a language that is accessible, and I really appreciate it. And thank you so much, Moises, for your thoughtful comments. And for the people that join us today, this webinar will be also uploaded to YouTube. So if you want to watch it, you can find it there. Make sure that as you exit, you fill out the survey. And thank you all for joining.
Thank you,
Bye,
Daniel.
everyone. Thank you again,
Thank you,
Carlos.
Carlos.
Thank you, Moises. Bye.